so as Andy mentioned, give the background about myself. And in the past, again, because there wasn't treatment options available that were approved, it was sort of like, well, try this, do this, do this. But now the APA recommends that, hey, if you have a patient with TD, please treat them. Please treat them. It's not just, oh, trying to blind eye to it or try to do things that don't work. No, actually treat them. And that's from the APA, not from Neurocrine, not from Tariq. And lastly, but most importantly, of course, the impact on our loved ones, right? So the impact that TD has, whether it's social, whether it's physical, whether it's for employment, all these things that, and we'll talk about that a little bit further in the slide there. So those are sort of the 5 whys to care about TD. I know, again, in Oklahoma, you guys have a robust program when it comes to those with IDD and those with mental illness. I've had a pleasure of talking to and presenting to people at Red Rock there, at Green Country, Child and Family, all your big CMHC in Oklahoma, and they've been wonderful and very receptive to this education. So, so before I go any further, I know we're on virtual and a lot of people are not on the call. Andy and Lorna, I see your faces there, but maybe you can do like your thumbs up emoji. How many of y'all have actually heard of or have seen or know someone with tardive dyskinesia? Like I said, you can put a thumbs up on your screen, just so I get a sense of people here in terms of what they've encountered with that. Let's see. Okay, 1, 2. Okay, great. 3. Okay, so 2, 4, 6, 8. So 2, 3. So 2, 4, 6, 8, 10, 12. So the 12 people here on the call, not counting myself, 11. So about half of y'all have either seen someone or, okay, great. And for those of you, and again, you don't have to get on video, but for those of you who have seen TD or have know someone with TD, how did it look like for you? And what did you think about that patient, your loved one, or whomever it was with TD? I'm just curious to kind of poll the audience. Just 1 or 2 people can volunteer, or 1 person.
Random movements, jerking their hand, blinking.
And Andy, again, I'm kind of putting in a spot here, but did that person appear to be comfortable?
It varied. It depended on their situation where they were. They were comfortable with people that worked with them, or family. But if they had to go out to a meeting or a presentation or was meeting somebody new, it bothered them a little bit.
Wow. Thank you for sharing. Deidre, you got on the video. Do you want to share your story as well? Or is that just accidental getting on video?
It was accidental.
Oh, okay. Okay. Hey, thank you. That's fine. I appreciate the accidental participation. You're good. Anyone else in the audience want to share really quickly?
I was going to say the mouth movements, like the uncontrolled mouth movements.
Yeah, Lorna, exactly. I mean, I'm talking right now to y'all, so my lips should be moving, right? Lorna and Andy, we see them on video right now. There's Esther. Hello, Esther. Esther's mouth, unless you're speaking right now, your mouth should not be moving, right? And that's the essence of TD, and that's something we'll talk about here shortly in terms of that. So for those that shared, thank you. And for those that have seen it, again, it's you know what it looks like, you've seen it. And for those who have not, we will have some real patient videos today to show you what TD looks like and how it can affect different body parts. Lorna, as she mentioned, often when people think of TD classically, think of the mouth, lips, and tongue area. But as we'll see, it can actually impact many other body parts as well, which makes this, again, really a debilitating disease process for those that suffer from it. So again, title today is Let's Talk TD, an overview of tardive dyskinesia. Quick reminder, I got to read this disclaimer here that this is a presentation intended for educational purposes only and is not intended to provide medical advice. If you have any questions about your personal health and or treatments, please consult with the healthcare provider regarding individual and appropriate use of specific therapies. The presenters are employees of Neurocrine Biosciences Incorporated. So I had to get that out of the way for the legalese. Continuing on, so this is our agenda. And again, it's not a long slide deck, y'all. It's only about 20 slides, I promise. And it's a lot of photos and videos in there. So it's going to be fun. So we're going to talk about TD, kind of an overview of the actual term and the definition of it. We're going to talk about the presentation, what it looks like, the diagnosis of TD, how that's done, how we approached treating TD, a quick little summary, and then we can have some time for discussion if there's time at the end. So, all right, so introducing TD. So what is tardive dyskinesia, right? It's a fancy term here. So TD is a condition where uncontrollable movements affect the face, the torso, so in the bit between your shoulders and your hips, right? You hold your chest area basically in your abdominal area, and then of course your limbs, your hands, your fingers, your feet, your toes, right? So tardive dyskinesia, much like other terms in medicine, is a Latin term, right? So the two words are tardive dyskinesia. No one in this group I know is going to know this tardive one because no one's ever late here. You guys were so great. But tardive means delayed onset, as in tardy, right? When you're tardy to school, tardy to class, tardy to a meeting, you're late to a meeting. So tardive means delayed. It's a movement disorder that doesn't happen right away. Often it takes months to years of you taking an antipsychotic or having been exposed to it until a patient develops the movements, right? And then dyskinesia. So dys in medicine always means abnormal, and kinesia means movements. So fancy way of saying abnormal movements. So in total, tardive dyskinesia are delayed onset, abnormal movements, right? And again, why are they abnormal? Because again, at rest, as Esther and you're demonstrating, you should not have any movements if you don't have TD, right? It's not normal to be moving your body parts uncontrollably, right? So what is TD associated with? Again, it's associated with antipsychotics primarily, right? They are the underlying cause of tardive dyskinesia. And we'll talk about a little bit later on the slide as to how mechanistically that works. So I'll explain a little bit further, right? And these are medications that we use to treat schizophrenia, bipolar disorder, depression, agitation, and nausea and vomiting. You're like, Tariq, nausea and vomiting, correct. So medications like metoclopramide, Reglan. So for the ladies on this call here today, back in the old days, some doctors still use it. When unfortunately you experience nausea and vomiting during pregnancy, they would give female patients Reglan, which actually acts exactly like an antipsychotic and has caused TD as well too. So, but for today's discussion, for Nami purposes, we're going to focus on antipsychotics. Okay, so those are the ones that are the culprit for this. And as we know, there's been expanded use of antipsychotics, and we'll see a graph here shortly. So again, the reason we think this happens is because the body, some of you probably heard the term homeostasis, wants to always maintain homeostasis. When we do a change to it, it says, I don't think so, Esther, I don't think so, Andy, I'm going to get myself back to my baseline. So when we're giving them antipsychotics and we're blocking dopamine, the body says, I don't think so, Tariq, I'm going to create more dopamine receptors. And so we kind of think that that malfunction there, essentially, of the signaling is how TD comes about. We don't know 100% why it happens, but that's the sort of leading hypothesis for it. So a lot to be still studied for it. And of course, do not change or stop taking your medications without talking to your healthcare provider first. So very important. All right. So this chart is a really, I think it's a sad chart, but I call it my sign of the times chart. And let me explain what I mean by that, right? So antipsychotic use has increased dramatically in the past 25 years. So here we see the number of antipsychotic prescriptions in 1992, which is about 15 million. And the most recent data that we had was for 2017, so almost now 7 years ago, at 66 million, right? So this was a 4 times increase in the number of antipsychotics being prescribed. In other words, this is a fancy way of saying a 400% increase. Now, to put that in perspective for you, Esther, I'm going to have you participate since you're on video today. You can get off mute if you want to and participate. If not, you can pass the baton to a friend or phone a friend. There's no right or wrong answer here. But to put this in perspective, do you want to guess what the U.S. population was in 1992, roughly, rough estimate? Or anyone can guess as well. Deidre, Paula, Trisha, anyone else that wants to guess too, you can guess just rough estimate. What do you think the U.S. population was in 1992?
200 million.
Lorna for the win. Yes, close, 250 million. Thank you for participating. Yes, super close. So 250 million, yeah. Right? So what do you think the population was in 2017? Oh, Esther's off mute now. Esther, take a guess. In 2017, what was the U.S. population? And here's a hint. It was more than 250 million.
Twice as much, 500 million.
Very close, very close. 325 million. So about a 75 million increase in that time frame. Now, why is that significant? Because from 250 to 325, that's a 33% increase in the population, right?
Yeah.
So the U.S. population went up by 33%, yet the number of antipsychotics being prescribed was a 400% increase.
Wow.
You see the problem, right? So that's why we have a little problem there. So as I mentioned a moment ago, as we saw earlier from the previous slide, again, although antipsychotics are, again, primarily used for psychosis associated with schizophrenia, but also with, let's say, mania and depression with bipolar disorder, they're also now approved, of course, as an adjunctive for major depression disorder, right? Major depressive disorder. But also, unfortunately, many antipsychotics are used off-label as well, right? for anxiety, for sleep, right? Who has heard of a medication called Seroquel? Anyone know Seroquel? There.
I have.
Deidre, when you heard of Seroquel, what was it used for? Do you remember what it was used for?
Sleep, I believe. To help with sleep.
Yeah, right. Okay, we got a chat here. Let me see what the chat says. Sure. Okay, cool. Thank you. Sleep, right? So many people think, oh, Seroquel, it's a sleep medicine, because my loved one I knew, my family member, myself, I was given Seroquel for sleep. Guess what, y'all? Newsflash. Seroquel is an antipsychotic. It is not a sleep aid or sleep. Okay. There's many people out there who have developed TD from Seroquel. So please keep that in mind. That's always an aha moment for people. Like, wait a minute, Seroquel is antipsychotic. I'm like, it's not a sleep medicine. So please keep that in mind going forward, which is why we see these large numbers. And mind you, this is from 2017. So in the last 7 years, we had a little thing called the pandemic. A lot of people had some mental health crises. We're seeing this. I'm sure you guys in Nami, Oklahoma, are getting more calls than ever. So the use of antipsychotics has even gone, more than that since 2017. So again, the more antipsychotics are being prescribed, we expect to see what? Likely more TD cases, right? So volume metric, basically. More of this, we expect more of it. So thank you all for participating there. Esther, you're amazing. Great guest. And Lorna as well, too. So sorry I put you on the spot. Oh, by the way, I forgot to say this in the very, very beginning, and I'll come back to it later. For all of you on this call today, thank you for being here today. It only took us 65 years to get here. Esther's like, what? What are you talking about? We'll talk about that later. It'll make sense later, I promise. So thank you all for joining me today. So again, TD may be more common than previously considered, right? So unfortunately, and again, I've been in your state many, many times. I've presented, although many healthcare professionals are aware of this condition, Tardive dyskinesia, because it's been out of mind for so long, is often misdiagnosed or underdiagnosed, right? Many times I've seen, speaker providers, clinicians, and PCP doctors like, we don't see it here, and I'll be in the lobby of their clinic and I see patients moving around. I'm like, well, there's TD right there, but because it wasn't taught for so long, because there was no treatment for it, you basically kind of ignored it, right? You're like ignored it or gave inappropriate medication for it. So we have a lot of learning to do, and I'll explain why. That whole 65-year remark will make sense later as to why this misdiagnosis happens so much. So right now we estimate that about 600,000 people in the U.S. have TD. The number could be higher as well too than that even. And that seems like a kind of like a big number. You're like, well, is that big? Is that small? To put in perspective, Esther, have you ever been to Las Vegas, Esther?
Yes.
You have?
Yes.
Okay. Did you have a good time there, I hope?
I did many years ago.
Did you win some money?
No.
Sorry to hear that. Okay, well, at least you had a good time, so that's good.
Yes.
So the reason I use Las Vegas as an example is that this is the population of the city of Las Vegas, 600,000 people. So again, in a vacuum in of itself, it means nothing. But when you put it in that perspective, you can see how prevalent TD is. And like I said, the more antipsychotics are being prescribed, we expect these numbers to go higher over the future, right? So, and as Dr. Odunukwe said, yes, but so she's right. So again, antipsychotics do have sedative qualities, which is why some prescribers will use it for the sleep purposes. But again, these are antipsychotics, and those are being used off-label for the unintended purposes. But yes, one of the side effects can be drowsiness or sleepiness, right? But many people don't know that, for example, Seroquel is an antipsychotic, not a sleep medicine. So, Dr. Odanuka, thank you for that. That's a great point she made. So, all right. So earlier I talked about one of the 4 whys as to why we should care about TD. So here's one of it right here, right? Is the prevalence. So here we see we're comparing on the left, this darker green is the first generation antipsychotics, and then the lighter one is the second generation antipsychotics. So the annual incidence, meaning the number of new cases per year, is always going to be higher in first generation versus second generation. So that was one of the benefits of the second generation antipsychotics, was that there's going to be a lower rate of these movement disorders, including Tardive dyskinesia, which, as we see, is true, right? Now, prevalence is over a patient's lifetime. So over your loved one's lifetime, if you're taking antipsychotic, what's the odds of them getting TD and developing it, right? So for those who've only ever been on a first generation, it's pretty high. It's about 30%. So 1 in 3 people will develop it over their lifetime. Those who are currently on a second generation, which again is supposed to be safer, but at some point may have been on a first generation, guess what? It's 20%. About 1 in 5 of them will develop it. And then those who have only been on a second generation, which again is supposed to be safer, and never had a first generation antipsychotic. So a second generation, for example, would be like Seroquel, right? It's 7% over their lifetime. Now, what number is missing on here, Esther?
I
Hint.
don't know. 50, 0.
0, exact. Good answer. Esther's on it today. I appreciate you. 0. So there's no 0 incidence or prevalence. So there's no risk-free antipsychotics, right? So no matter what, there's always a risk, even with second generation.
Mm.
So it's missing. So please keep that in mind. Okay. So all right, the presentation and diagnosis of TD. So we have this little human here, our little blue human, we call him, our blue man or blue woman, our blue person, I should say, excuse me. And so we have this on here to kind of highlight the different parts of the body that TD can affect. Okay. So it can affect the eyes, right? So excessive blinking or squinting, right? That's actually a form of TD, believe it or not. Even I didn't know that before working at Neurocrine. I always thought, hey, but I didn't know that if you're on antipsychotic and now they've had excessive blinking or squinting for a long period of time, again, that could be tardive dyskinesia. Esther, I'm so sorry I cut you off. You're going to say something.
No, I wasn't.
The jaw, right? So this is the classic, the biting, clenching, doing all that, right? The lips, the puckering, the pouting, right? The tongue sticking in and out like a lizard or dancing inside the mouth, right? The torso rocking, shifting back and forth, the fingers moving around, the toes, and we'll see some videos of this real stuff, right? So please keep in mind, and I think this is to Lorna's point earlier when I said, have any of you seen TD? And she says, yes, I have. That again, or maybe Madam Andy, I apologize, but the movements can differ from day to day. I think it was Andy, where some of the movements can be more prominent during times of stress, during times when they're more activated, they've done some movements or walked around a little bit, or they ran. The movements are going to appear more bigger, right? It might be worse in the daytime versus nighttime or vice versa. So there's no consistency to the movements, right? Other patients may have it all day long at the same intensity. It could be just the whole day, nonstop, like this all day long, right? But others may have variations. Some might be more prominent than others, right? The movements can be quick and fast, rapid and jerky, or they can be slow. So again, there's no one way. As we say at Neurocrine, when you've seen one case of TD, you've seen one case of TD because it's unique for every person. So keep that in mind. And again, the movements are repetitive and continuous in a random pattern. So many people who see, in fact, many clinicians, I talk to doctors, NPs, PAs, they'll see this little tremor-like movement, like someone has Parkinson's disease, right? And they'll think, oh, hey, that's TD. But remember, those movements are regular, rhythmic, repetitive, and that is not a TD movement. TD movements, as we see here, are a random pattern. Yes, they repeat over and over again, but they're often, irregular, right? So there's no regularity to them. There's no rhythm to them, okay? So keep that in mind as well, please. Now, one of the bad things about TD is that in about 75% of TD cases, it's from the neck up, right? It's from the neck up, Esther. There was one group of people who during the pandemic, unfortunately, were happy about wearing masks. And those were people with TD from the neck up. Why? Because it could cover their faces up with them, right? So in this day and age of telehealth, TikTok and Messenger and WhatsApp, if you're doing a video, Zoom calls, guess what? You can't hide it. It's from the neck up. We all see this. Everyone sees it from here. Maybe if you had it on your toes, you can hide it, but not from the neck up. And 75% of TD cases include something from the neck up, whether it's the tongue, the lips, the mouth, the jaw, the eyes. So again, very, very stigmatizing. Now, let's see where the rubber meets the road here. So now we're going to actually see, unfortunately, real cases of real patients that have TD. And what I want you to focus on is on a couple of things here, a couple of key takeaway points from these next few videos. One is that can happen to anyone. Does not matter. Black, white, Hispanic, male or female. Number two, the ages. old or young. A lot of people think, oh, TD only happens to older adults because they've been taking antipsychotics for a long time. Not true. It can happen to young adults, it can happen to children even as well too, right? So again, TD does not discriminate in saying, hey, I'm not going to get you. No, it's an equalizer. Everyone's fair game. In a little bit, we'll talk about risk factors that increase the risk of you developing TD. But again, the key point is to show you that it's a mix of people. Second key takeaway is to show you how the movements vary. Like I said, classically, when you talk about TD, most people will say, oh yeah, I've seen TD. And you'll say, describe it for me. They'll say, the mouth doing that. And I say, that's right. That is definitely a form of TD. But as we'll see here shortly, we're seeing real patients, and you can see how the different manifestations of TD present itself. And one of the key takeaways from this is now that you see this, it makes you a better advocate for those with TD, because you can say now, does that person have TD? I've seen something like that on a video once. So again, that's the idea, to really kind of broaden your horizon of what TD looks like. And this is also shocking to clinicians as well. They learn from it. They're like, oh my gosh, I had no idea that that can be TD. So it's a very, very valuable educational tool. So without further ado, we'll go ahead and start the videos here. So here's our first patient. It's a older adult patient, female, and she's got the classic lip smacking, of course, the puckering, the pursing, but also the blinking as well too, right? So as you can see with TD, oftentimes, more times than not, it affects more than one body part as well too. It's not just isolated to just one body part. Here we have multiple things moving here, right? Gentleman here, he's got the sort of the sad look, right? So got a little grimacing on his mouth. So again, think about, we unfortunately as a society, as humans, our eyes tell a lot about someone. So we're gonna form impressions about someone and make judgment calls based on what we're seeing. And this gentleman, he may be the happiest guy in the world, right? He could have a great disposition, a cheerful attitude. But as we look at him, does he look really happy, Esther, right now? Does he look like a happy person you want to go talk to?
No.
Maybe?
No.
He looks a little depressed, a little sad looking, right?
Sad, yeah.
But again, that grimacing, the mouth, the sad moving of it, that's from the TD, make him look like that, unfortunately, right? So. There's a young lady here. So like I said, old, young, does not matter, right? And here's the thing with the young lady like this, right? So again, society, unfortunately, whether you're in Tulsa, Texas, whatever state you're in, people are going to judge, and it is what it is. Unfortunately, that's where we live in. So who's that? Ray was on video a moment ago, and I guess Esther's on the call. So Esther, so this young lady, let's say, has struggled with bipolar disorder. She was given antipsychotics. She's doing well. Now, maybe she's your neighbor. She's doing well. And she's like, hey, Esther, do you mind helping me get a job? I'd love for you, if you know someone that's hiring, I want to get my life together, and I'd love to go work. So number one, would you feel comfortable taking her to a job the way she looks like? And number two, do you think the employer would want to hire her?
No, they probably wouldn't. Because she looks distressed.
Looks distressed, right? What might the employer think with her tattoos and her mouth doing that? Her tongue.
I didn't hear you.
I'm sorry. If you're an employer, or if you're a person walking down the street and you see this young lady walking by you with tattoos and her mouth doing this, what would you think that she's doing?
They're going to assume drugs.
Ray, exactly, right? Unfortunately, like I said, we judge. And I know in Oklahoma, whether it's Oklahoma City or Tulsa, there is unfortunately a big meth problem. So you're going to think, oh, she's on meth. Look at her, tweaked out, walking around the neighborhood. Or maybe she has beautiful children at home, right? And she drops them off at school. Parents are going to think, oh my God, this lady's putting her child at endangerment because she's high on meth, dropping her kids off. Is that fair to say?
No.
It's not fair. I agree. But that's what people are going to think. I had a case I was presenting once in Amarillo, Texas, West Texas, where one of the audience members shared with me that one of her patients was at a Walmart, okay, with her, I believe it was her granddaughter. It was a granddaughter. They were there and at Walmart shopping, it's daytime. And next thing you know, the Amarillo police come up out of nowhere, take her down and arrest her. And the granddaughter is, crying and screaming. Well, what had happened was that some shoppers who were there saw this woman who had similar movements to her. The mouth was moving, doing that, and they thought she was under the influence of drugs. Called the police saying, "Hey, there's a young lady here. There's a child here who's engaged right now with the adult who's high on meth right now.
Mm.
That's when we talk about impact of TD, that's the impact of TD and the stigma that it can have. So, and there we go. Yes, Dr. Ondenukwe said exactly. Sometimes they're mistaken for drug use, particularly meth, especially with the lip smacking. Exactly. Right? So, and I know in Oklahoma, again, I'm from California originally. Here in the sort of the central south area, I know that people's faith is very important to them. Church is a good place. It's a place that's important to many people. It's a sense of community. It's a big thing here in the South. So this gentleman, we see him prominently wearing his cross, likely that his faith is important to him. Do you think, Esther, this gentleman would feel comfortable going to church on Sunday, looking like that and doing that?
No, he wouldn't.
And it's likely that his faith and his fellow parishioners are a good source of support for him, people he wants to hang around with and talk with, grab lunch afterwards with. But he can, because look at this. It looks like this, right?
He's
He may think, I
twitching.
don't want people to judge me, right? So he may just stay home and miss a very important part of his identity, right? And let's say he has depression. Do you think him staying home from church and not going and seeing his friends and his parishioners will make his depression worse or better?
Be worse.
Worse, exactly. So again, we don't, as clinicians, we don't often think about the impact. We just think, oh, they're having funny movements. But again, put yourself in their shoes, right? Think of this, if this is your neighbor, your loved one, how will society look at them and judge them, and how are they being impacted by those movements? So another young lady here, cheek puffing. Again, I didn't know. I'm gonna acknowledge my ignorance. I didn't know that cheek puffing is a form of tardive dyskinesia. So we see her cheeks puffing out. She also has truncal T. You see how she's breathing abnormally. Her body's kind of rising. Again, TD can also affect the diaphragm, which is that muscle below your lungs that helps you breathe, pushes your lungs up and down. So she has that. So she has this irregular breathing pattern. You see how she's kind of does that? That's not normal, right? I don't see Astrid breathing like that. I don't see Lorna breathing like that. I don't see Annie breathing like that. That is abnormal. So again, it affects many, many body parts. And then finally, our young lady here who has the mouth movements, right? And now we have what's called, this is actually called piano playing toes, where her feet are doing that. Oh. I know it gets hot in Tulsa. It gets hot in Oklahoma. I've spent some summer days out there. So Andy's smiling there. She knows. So Andy, on those hot Oklahoma days, this poor woman, do you think she's gonna be out there in her open strap shoes and walking around and stuff?
Yep. Well, she may not because she's aware, but
Hi,
it's
Jason. Just want to add something too. What do you think?
What? Sorry, I've just been walking around and I had my video off. I'm at the Capitol, but I don't know. I didn't have anything to say. I just wanted to turn my video on to show that I am indeed here. Sorry.
Jason just wanted to show us that they're the most fashionable person on this call today. That's all. So thank you for that. So I've lost that crown. I had it for about 1 minute and now I've lost it. So thank you. So you look great, madam. Very fashionable. But now I know why, it's State Capitol. So again, now we saw the different presentations of TD, y'all. You can see how diverse it is, just like the patients are diverse, and the stigma and what can be associated, what people can think about these people based upon purely their movements without even knowing them or speaking with them. So again, Esther, thank you much for your participation, Ray as well, and Jason as well too. So thank you all for that, and Lorna and Andy as well. So assessment of TD, how do we assess TD and diagnose TD, right? So again, TD can be assessed by your primary healthcare provider, which is your psychiatrist, your psych NP, your psych PA, or your PCP, but oftentimes it's your psych person or someone in neurology. Now, one of the wonderful things, and unfortunately, one of the, I guess, bright spots of the COVID pandemic. Oh, we have another friend on the call too. Hello, Annie's dog. Very sweet. One of the cool things that happened with the COVID pandemic was the expanded use and accepted use of telehealth, which has been wonderful, especially in psychiatry, where many people in the rural areas or people cannot leave home have now access to mental health services, which is fantastic, right? That's amazing. And I'm so happy as a clinician, as someone with a loved one who had mental illness, this is great. But with anything in life, there's always some pros and some not so good things, right? One of the downsides of that, unfortunately, was you lose some of the personal connection. But when it comes to TD, we can't fully assess the patient for movements, right? Maybe the video quality is not good, right? Maybe the patient does not want to get on video, right? Or all you're seeing is up here, right? So unless you ask your patient to step back and do a full body eval, you're going to miss the fingers, the toes, the trunk, as we saw, right? So because of that, we do recommend that, your loved one, patient, whomever, your family friend, whomever it is that may be having TD or has TD, to go at least once a year in person with their provider to go get assessed fully, right? For the TD, to make sure that the movements are stable or they're getting worse. So if they can, at least once a year in person would be great. So, and then when you do see your PCP or your psychiatry person, they will likely do an exam called the Ames exam to see how severe the movements are. And they may ask you questions to help them diagnose, like, when do the movements occur? How do these movements affect your thoughts and feelings? When do your movements start and how frequently do they occur? Have others noticed your movements? So these are the kind of questions that the clinician should be asking you. Many times they don't, unfortunately, due to time constraints. I know they're busy. They're trying to see it in all these people in a short amount of time. They don't have enough time to ask all these questions. So again, with your role and the people on this call, as advocates for yourself or for your loved ones or whomever it is that has mental illness, you can be the one to speak up to the provider and say, hey, by the way, I noticed movements in my loved one the last 6 months. Or, hey, by the way, I noticed that she's been more withdrawn, or he's been more withdrawn. Or, hey, I noticed in the last, 2 months that, the toes started moving a little bit. So that clues in the clinician to look for that further. And that's where family, your caregiver, guardian, whomever, advocate can be such a big part of that. So now let's talk about risk factors for TD. So again, these are the factors. So just any other disease process, whether it's heart disease or diabetes, right? So heart disease, if someone smokes, that's a risk factor. It puts you at elevated risk of having a heart attack, for example. If you have a family history of heart disease, puts you at elevated risk of having a heart attack, for example, right? If you don't exercise, puts you at higher risk of having a heart attack, right? So each of the risk factors increase the risk of you having a coronary or a heart event, right? Same thing with TD, it's no different. So each of these are individual risk factors that can contribute to someone having a higher chance of developing TD, right? And the more of these they have, the more risk factors, again, the higher the chance of them developing TD. So again, cumulative exposure to antipsychotics. As Dr. Odenukwe knows, there's medications out there, antipsychotics, that are approved for children from the age of 5 and up. So imagine a child who's been on antipsychotics since the age of 5, as now as an adult, right? That's a long time being exposed to antipsychotic, unfortunately. Long time, Esther. Treatment with anticholinergics such as cogentin. A lot of you probably have heard of cogentin or benztropine. That's the risk factor. That was something that doctors used to think would help TD. In fact, it makes it worse. There's also a risk factor for it. The potency of the antipsychotic, again, was, there's different ones that are more potent, less potent. So dependent potency. If you've had other movement disorders with your antipsychotics, like if you had akathisia or dystonia, that puts them at increased risk. Increased age. So like I said, although we saw that TD can affect everyone across the age spectrum, older adults are more likely to develop it. They're more fragile, so they can develop. So always keep in mind of your older adults that are on antipsychotics or have been exposed to it. Okay. Here's a big one, again, that we talked about earlier that Dr. Odenukwe, myself, and others have mentioned. Unfortunately, methamphetamine use, as we know, mental health, unfortunately, and substance abuse are like peanut butter and jelly. They go together. So anyone that has a history of cocaine use or methamphetamine use does put them at a higher chance of developing TD. Diagnosis of a mood disorder, so if they have a history of depression, anxiety, bipolar, puts them at an increased risk of developing TD, right? And then, ladies, I apologize, I don't make the rules here, but postmenopausal women also are at risk because we think that estrogen is protective against TD. So again, so your older females, really be mindful of them, right? So very important. So and again, the impact, right? So this has been a common theme, and that's something that Nami does such a great job of always talking about, raising awareness of mental illness, both to the patient, but also to the society, to the community, of what it means when it comes to mental illness. In this case, we're talking about the impact of TD for your loved one or a patient with TD. So again, it can impact your quality of life, including their ability to speak, to move, to interact with others, as we all saw today, right? It can have a negative impact on your activities of daily living, on your posture, on your speech, right? And this can all lead to what? It can lead to, so those with mental illness, right, especially, unfortunately, in the states here in the South, it's already a lot of stigma associated with it. Like, hey, that's what's wrong with you. Just pray it out. Like, no, that's not going to help, unfortunately, all the time, right? You kind of sometimes need therapy, you need medications. So what it can lead to is that, with these movements can lead to what? More social withdrawal, right? Which can possibly increase your anxiety, increase your depression. It can lead them to be feeling embarrassed in public, as we saw the gentleman maybe not going to church because of his TD, making others feel uncomfortable, right? Like you walk in a room, you see someone like, for example, you see someone in a bus let's say it was a schizophrenic having auditory hallucinations, he's hearing voices, so he's talking to himself. So when people usually see that person on the bus, will they sit next to that person? No, they sit away from them, right? They're like, I don't want to sit next to that person. Why is he talking like that and talk to himself, right? So with TD, same thing. People think, oh, what is that? What is that weirdo doing? I'm not gonna sit by them, And they start feeling, they grab the kids and say, like, hey, let's get out of here. And then, of course, the physical impact, right? So like I said, the older ladies who are more at risk of developing TD, what do we think about for them? If they have TD of the feet or the trunk, they're unstable, right? And unfortunately, for my ladies here, the one big thing we worry about when we get older is what? Osteoporosis, right? Fragile bones. So you have a female patient with TD who's unsteady on her feet. If God forbid she falls, she's at more risk of what? Breaking her bone, breaking a hip, right? Going to surgery, going to nursing home, it's just all bad there. So thinking about all these things that can be affected when it comes to TD. So approaches to TD treatment. Let's talk about how do we treat TD and what's changed in the last few years. So a brief history of TD. So pop quiz, here we go. It's a cool little, I guess, mental health fact, is that the first antipsychotic that was commercially available, y'all, was chlorpromazine, also known as Thorazine. So Thorazine was the first commercially available antipsychotic. And when did it come out, y'all? 1952. Okay, 1952. And the first cases of TD, remember I said it doesn't happen right away? The first cases were in 1957. So only 5 years later, after being treated with antipsychotics, they already developed a TD. The very first cases were reported only 5 years later. Okay. And again, like I said, in 1992 is when the APA, the American Psychiatric Association, I had the first report on TD, right? And then only in 2020 they actually have a new guidelines published. Now that we have the medications available, saying, hey, if you see TD, to please treat it. Now, I remember earlier, Esther, I said, hey, thank you all for being patient. It took us 65 years to get here. This is what I meant. So in 2017 is when the 2 FDA-approved VMAT2 inhibitors, the medications used to treat TD, came out in 2017. So when I said 65 years, what I meant by that is that 2017 minus 1952 is 65 years. So for 65 years, these patients in 1957 and everyone thereafter who had TD, all that stuff, those movements, they suffered. There was no treatment for it for 65 years. They had their mental illness, the voices in their head, the manic episodes, taking antipsychotics every day, and then they developed TD. And once they developed TD, for the time until 2017, there was nothing we could do about it. This is also why many doctors, NPs, PAs who were trained before this don't know as much about TD because, again, there was no treatment for it. You saw it, you did what you could with it, but you don't do much because you're like, okay, what can I do? I can't treat it. So that's why the education component is so important. We strive so much. And as Nami has been a great partner to raise awareness, to say, hey, guys, again, it's more common. And now with these treatments for it, which is a great big development for that, right? So how do the VMAT2 inhibitors work? So how these medications work. So remember earlier I talked about, so these little orange balls are the actual dopamine neurotransmitter, right? We need dopamine. It's a good thing for us. Our body needs it to function. So what happens, those with, let's say, schizophrenia that have psychosis, right? They hear voices. The problem with that is there's too much dopamine in a certain tract of the brain, right? It's producing too much. So we're trying to reduce that. So in the normal signaling, the dopamine gets released from the presynaptic neuron. It's this little area called the cleft, the presynaptic cleft, and then it binds to these little arrows here, which are the dopamine 2 receptors, and then it has a message. That's how our whole body works. A transmitter gets released, it binds, it sends a signal. Okay. What happens with antipsychotics, these little green half moons here, you give a patient antipsychotic, it blocks the receptor, saying, hey, look, there's too much dopamine. This person having hearing voices. Let's do this to block it so that there's less dopamine available to hopefully the voices in their head go down, right? So that's great. It works, wonderful. But like I said, the body is smart. It says, I don't think so, Esther. I don't think so, Jason. I'm going to maintain homeostasis. I like my dopamine. I want my dopamine. So what it does, it creates more of these receptors, right? These are the D2 receptors. It creates more and then makes those more sensitive. So by doing that, now when dopamine does get released and it binds to that, that's when we think that excessive signal happens and we get TD. So what these medications do, these VMAT2 inhibitors, this is, again, this little star is a VMAT2 medication. What it does is it binds to this vesicle in which the dopamine is stored in, and it binds reversibly. So it doesn't stay on there forever. It binds on there. It blocks the dopamine from being packaged in there for release later. And by doing that, because there's less dopamine available, we believe that that's how it helps with TD. So therefore, there's less dopamine hitting these very, very sensitive receptors. And so therefore the TD gets either less or, it's basically gone, while you're at treatment. Now keep in mind when the patients get off treatment, they stop taking their medications. So just like with antipsychotics and the voices go away, but if they stop taking their medication, what happens? The voices come back, right? Same thing with TD. Once they stop taking medications for it, unfortunately, the movements do come back, right? So again, it's a lifelong disorder. We can't cure it, we can only treat it. So finally, in summary, again, TD is a condition in which there's uncontrollable movements of, again, all body parts, basically, as we saw, from head to toe. It's associated with the use of antipsychotics, right, for a long time, but it can be short time. It can be a few years even, and it can have TD. Telehealth has been amazing for us in psychiatry, especially to offer services, but it does have its limitations. We recommend at least coming in once a year to get assessed for movements to your whole body. We know that TD can affect the patient's quality of life in many, many ways. And now there's actual guidelines saying to treat those with TD, no longer can you just turn a blind eye to it. So with that said, ladies and gentlemen, thank you for your time. That was my presentations. So now I'm going to open up to the audience for any questions, comments, feedback. So, and you can also go, if you want more information, go here at Neurocrine Medical or call the number if you'd like more information.
Are you
I have a
finding
quick-
less?
Yes.
Go ahead.
I have a question. So I have a family member who takes Seroquel for sleep. Will their chances of developing tardive dyskinesia increase the longer they take it?
Exactly, Lorna. Yep. So as we saw earlier, so one of the risk factors, main risk factors is, cumulative exposure to antipsychotics, right? So the longer they're on it, the exposure level goes higher and higher and higher. So, so yes, we don't know. There's no set level. Everyone's gonna be different. As to this person. I mean, it could be a good chance that your loved one never even has TD, right? But there's always risk of the longer you take something. It's like with smoking. You can, the longer you smoke, the chances of you getting lung cancer go higher, right? The more years you smoke, So it's no different. We don't know what the cutoff is, but yes, the longer they're on it, there's always that risk goes up. So, great question.
Are you seeing with the newer medications less impact or more? Are they addressing that a little easier with some of the newer medications?
Yeah, great question, Andy. Wonderful question. So, yeah, so again, as I mentioned, the second generation. So what the trade-offs in life is always about trade-offs, right? You can't always have a free lunch. So with second generation antipsychotics such as Seroquel, such as Zyprexa, such as Abilify, the idea was, hey, look, why they're called second generation is because their binding to the D2 is a little bit less. They have other receptors they hit on, meaning, okay, there's less chance of them developing movement disorders or what's called EPS. Some of you have heard the term EPS before, extrapyramidal symptoms. They're less likely to develop EPS like dystonia, akathisia, drug-induced Parkinsonism, and TD with the second generation. But it didn't come with the free lunch. We said, okay, that's cool, we can do that. But the trade-off, as we know, with second generations, they have metabolic side effects, meaning they cause weight gain. It can lead to diabetes, blood sugars levels are abnormally or can go higher, right? So which is why if you ever have a loved one that takes a second generation antipsychotic, when you go to your doctor's office, they often check your weights, your blood sugar, your A1C, your lipids even to monitor for these metabolic side effects, which carries its own risk, right? Increase the risk of heart attack, diabetes, all that. So again, no free lunch. But as it pertains to TD, again, the thought is that second generation are lower, but as you saw here, as you saw with here, it is not zero, right? That's not the case. So, so again, it's better, but it's not zero. So it's a step in the right direction. Great question, Andy. Great question.
We have a question in the chat. Do they still use Artane as a side effect medication?
Oh my gosh, that's a great question. So, who is that from? Oh my gosh, let's see who that was. That's a great question. Sorry, I don't know why I can't see my
Dr.
messages. Okay.
Susan, and I don't want to mess up her last name.
Yeah, Dr. Anuka, great question. Yeah, so what she's referring to, y'all. So again, as I mentioned, as we saw, benztropine. So benztropine is a generic name, Cogentin is a trade name, and what Dr. Anuka is referring to, Artane is the trade name, is the trade name. Trihexyphenidyl is a generic name for it. So both Cogentin and Artane, y'all, are what's called anti-Parkinsonian, anticholinergics. So in the old days in medicine, what they would do in psychiatry, two things would happen. like when I was trained, even in PA school, when I was in PA school a few years ago, and this is just in 2014 or so, the psychiatrists, when I was practicing with, what they would do is when they would treat a patient who, let's say, came in for their first episode psychosis or bipolar, they'd never been an antipsychotic before, my doctor was so worried about them developing it, and many doctors still do this, sadly, to this day, is they'll start them on an antipsychotic and then add the cogentin or the Artane with it to prevent a movement disorder from happening, which we know now is not the right way to do it. But even to this day, that still happens. So that's one thing they were doing to prevent it from happening. They would put them on these medications. The second thing that I think Dr. Neurocrine was referring to is that then in the past, before the medications were available to treat TD, what physicians would do, a psychiatrist would do, was they would try to treat TD with Artane or with cogentin, which again, as we know, is not correct. The data does not support that. In fact, it's a risk factor, right? And these two medications are really bad because they dry people out. They make them a little bit dumber, like affect your cognition. So these are very, very toxic medications. But sadly, we still see that to this day and age. So those places that I can't go talk to and educate, they're still doing the old ways, and this is what they do. So I'm not practicing cogentin benzo a lot. What are some of the newly approved side effect meds? Dr. Neurocrine, so when you say what are some of the newly approved side effect meds? So great question. So I think, so with that said, so again, with EPS, the extrapyramidal symptoms, there's 4 movement disorders. There's akathisia, which you treat again by lowering the dose of antipsychotic or switching to another one, maybe using something like a beta blocker, right? Possibly. And then there's dystonia, which for that, we can use Benadryl, you're right, but that's a more emergent situation where they muscle freeze and they have that sustained muscle contraction. That's a freaky looking one, right? They use for that Benadryl, you can use that, or cogentin for that. But really, cogentin on the label, if anyone actually wants to do the little quick Google search on the go, because it's such an old medication, cogentin is actually only approved for drug-induced Parkinsonism, and it should only be used for a short period of time, and that's it. But as Dr. Neurocrine pointed out, sadly, it's used quite a bit still often, inappropriately, not following guidelines, but that's what we see because people just don't know, right? And so that's kind of, yeah. So, but for TD now, we know that that's not the case. You don't have to use it, nor is it recommended to use that, either Artane or cogentin or Benadryl. You have now 2 medications FDA approved indicated for the use of tardive dyskinesia. So those are great questions. Yeah, great question, Dr. Neurocrine.
Okay.
Great question. Yeah. Any other questions, y'all?
I have one. So on the risk factors, I know there's not, I don't see anything about family. So if you had someone who was on a medication and it caused them to get tardive dyskinesia, would you be at an increased risk of maybe developing that if you took a similar medication?
Wow, y'all asked the best questions. We don't have data currently to support such a thing, at this time. As far as actual genetics go, we know that there could be genetic polymorphisms in terms of TD. You're right. So there is, again, like I said, the accepted hypothesis as due to antipsychotic, but we do know there's other things that also go on, possibly genetics as well. We just don't have enough data to say conclusively that yes, there is a link, like there is with bipolar, for example, with depression, for example. But with TD, we don't have that data quite yet. With that said, I should note that this list here is not exhaustive. I know one of the things that Nami does, and I know Oklahoma has a very robust IDD program. You guys have a Department of Health and Mental Services that overlooks IDD. So the IDD population as well, they're actually at elevated risk of developing tardive dyskinesia. For that population, because IDD is a risk factor independent, since obviously something's wrong with your brain, unfortunately, and those patients are often given high dose antipsychotics for a long period of time for behaviors, right, and agitation and anger. That number, yeah, it's about 40-45% of them will develop TD over their lifetime. So basically 1 in 2 with IED, which is really sad. Another big one for this population, you all probably know a loved one or family member or whoever you care for that deals with this issue is intermittent antipsychotic use, meaning they start, they take your medications, they're antipsychotic, they're doing well, and they stop taking it for a while, right? And you get them back to the hospital, they get hospitalized, you're taking them back to the clinic, they're back on it again, okay, they're doing well, they stop taking it. Okay, things go bad again, you take them back in, they start, so that restart of antipsychotics as well, which is very common in psychiatry. Unfortunately, that's a risk factor. In fact, that increased the risk of developing TD 300%. It's a big one that a lot of people don't know about. With TD, have you found it to be? So Dr. Neurocrine, great question. So to my point, it's actually been shown that because the injectables, the long-acting injectables that we're used to, that we have for psychiatric patients, those antipsychotics that are given once every month or once every couple months. Because it's a steady state, to my point just a moment ago, they can't really be off the medication, and it's like given a dose slowly over that time frame. There's actually a lower risk of developing TD if they're on a long-acting injectable, assuming that they're consistent with it, right? But as I know, as a clinician, I'm sure many of you in this audience know, even with injectables, the patient may go missing, they may not want to take it. So then again, that counts as a stoppage. And then they get back restarted again, and then that's the whole cycle. So although, yes, long injectables, because there's a steady state of the medication being given over a 1 month, 2 month, 3 month, now 6 month period of time, it's nice, if they do that stop start and are not consistent with it, then again, that is a risk factor. So Ray, you had your hand up. Sorry, I'm going to ask Ray's question first, and then yes, I can do exactly. Yes, metagenic is a big issue. Hi, Ray.
Hi, it wasn't really a question, but just something that I noticed, like as a parent of a child that has autism, and I was looking at your video and I saw that blinking, and that excessive blinking many times is associated with something sensory, which is usually associated with something that has to do with autism. And then even with the patient that had the movements, the gentleman that had the cross on, like I'm not a medical professional. I'm not. But looking at that, honestly, my first thought was Parkinson's. So it's like all these different, some of these symptoms intermingle a lot. And then thinking about the excessive blinking, is it the autism or is it the medicine if your child's on antipsychotic? So that's something that stood out to me.
No, Ray, that's a wonderful point. So like I said, antipsychotics, although we talked about TD, the 4 movement disorders that they can cause are, again, akathisia, dystonia, drug-induced Parkinsonism, which is basically like Parkinson's disease. It looks exactly the same, except it's reversible. That's the key difference. And then TD. So there's 4, actually. And one of the things I've been doing over the last 4 years covering the state of Oklahoma in medical affairs is going out in the community and teaching those psychiatrists, NPs and PAs, nurses, the clinical managers, the ACT teams, about how to distinguish between the movement disorders, right? Because you're right, because each of them looks different, and then the treatment, as I mentioned a moment ago, is different. So can they get confused still? Absolutely. Even the best doctors still can mess it up. The best clinicians can still mix it up. But the more we can educate to show videos of what it looks like, what to ask the patients to help you distinguish it, you're right. So absolutely. So, and that happens even to the most best doctors, best NPs and PAs will still confuse them and not know. And you're right about that. So great point, actually. Great point about that. So. Any other questions or comments?
The use of a beta blocker with a medication used for tardive dyskinesia, is that contraindicated?
For someone that has TD, you mean, Esther?
Say that again.
You mean for someone with TD, like
with someone with TD?
They're being treated and then they need a beta blocker. No, as far as we know, the studies, there's nothing that shows any adverse events with someone that's on a beta blocker. So
okay.
Yeah. One of the things I know it's not on a slide today, but I know I talked about cogentin quite a bit, and Dr. Odenukwe made a wonderful point that, again, as I mentioned, as she's telling you as well too, that to this day there's still clinicians who still use cogentin and artane to treat TD or other movement disorders, or the patient may have been on it for a long time. What happens is it gives them a little natural high as well, so they're very resistant to come off of it, right, off of the artane or off the cogentin. In those instances, in our studies, in our clinical trials that we studied, we did have our subjects still remain on their cogentin because we knew in the real world this might be the case. And so they were still given the medication, and they still responded positively to the medication and still had reduction in their TD movement. So although, again, it shouldn't be that way, they shouldn't be on cogentin or artane. If we see in the real world, as Dr. Nukwe knows, and I know it happens, you can still give them, at least in our case, the VMAT2 inhibitor, and also help them with their movements, or at least it showed efficacy in the trials. But again, one of the good things about the medications, the VMAT2 inhibitors, is that they can remain on the antipsychotics that they're on, and you don't normally have to switch them off, because obviously the clinician, Dr. Nukwe, myself, their doctor, whomever, has helped to get them on a good place. They're finding a good regimen now. They're doing great. They're functional, or as good as they can be. And the last you want to do is to destabilize them, right? So they have TD now, but they have a good psychotropic regimen, well, guess what? You can usually add the VMAT2 inhibitor medication for the TD and not change your underlying psych meds. So that's one of the positives, which is great. So in most cases. Great question. Anyone else? These are great questions, y'all. Thank you for these insightful and very, very thoughtful questions. I mean, again, you guys are obviously, care a lot about this. And like I said, my parting words are that I appreciate each and one of you for all the work you do, whether you're a staff member, whether you're a family member, whether you're an advocate, because like I said, this is very, very personal as well as professional for me. So anyone that's in the mental health field that does their part and doing their little, whatever they can do, it makes a big, big difference. So from my bottom of my heart, y'all, thank you so very much. And thank you for this opportunity. So I really appreciate it.